And this system has a huge systemic impact because thyroid hormones influence virtually all major metabolic processes, from your heart rate and body temperature to your digestion and energy levels.
Okay, so TSH is the signal from the pituitary. How important is testing TSH itself?
Thyroid-stimulating hormone, or TSH, is truly the master switch in thyroid testing. Produced by your anterior pituitary, its primary function is stimulating the thyroid gland. Because of that feedback loop, TSH is often the first and most sensitive test ordered for thyroid disease.
The first one?
Often, yes. A normal TSH level typically rules out a primary thyroid disorder, a problem with the thyroid gland itself. For adults, a general normal range is usually somewhere between, say, 0.2 to 5.4 micronits per milliliter, though ranges vary slightly.
So understanding that feedback loop is key to interpreting TSH results.
Absolutely crucial. Let's take primary hypothyroidism. This is when the thyroid gland itself is failing, not making enough T3 and T4.
The factory is broken.
Right, so T3 and T4 levels will be low. Your pituitary senses this and tries to compensate by yelling louder. It releases more TSH. So you'll see low T3, T4, but a compensatory elevation of TSH.
High TSH, low T3, T4 equals problem in the thyroid.
Exactly. Now, conversely, in primary hyperthyroidism, the thyroid is overactive, turning out too much T3 and T4.
Factory's gone rogue.
Yeah. Those high T3, T4 levels then feedback and suppress TSH production by the pituitary. So you'll see high T3, T4, but very low or even undetectable TSH levels. The manager's whispering because the warehouse is overflowing.
Low TSH, high T3, T4 equals problem in the thyroid. Overactive.
Makes sense. What if TSH is low and T3, T4 are low?
That usually points to secondary hypothyroidism. The problem isn't the thyroid itself. It could work if stimulated, but higher up. The pituitary isn't adequately sending out the TSH signals to begin with, or maybe even the hypothalamus isn't sending TRH.
So the manager isn't giving the order.
Precisely. So TSH really helps us pinpoint where the problem might be originating in that whole axis. Okay, thyroid regulates metabolism. Let's move on to another vital set of endocrine glands. The parathyroid glands.
Tiny but mighty.
Right. You typically have 4 of these tiny glands, usually located on the back or sides of the thyroid lobes, although their exact anatomical location can vary a bit.
Yeah, they can sometimes be tricky to find surgically.
Their primary job is to produce and secrete parathyroid hormone, or PTH. What's PTH's main role?
These glands, via PTH, are absolutely crucial for maintaining mineral homeostasis. Specifically, the delicate balance of calcium and phosphorus in your body. They are truly calcium's vigilant guardians.
Calcium's guardians. I like that. How do they guard it? How is PTH regulated?
Their hormonal regulation is a direct, almost exquisite response to your blood calcium levels. The parathyroid glands are stimulated to secrete PTH specifically when there's a decrease in serum calcium.
Low calcium turns PTH on.
Exactly. Conversely, when serum calcium levels return to an adequate range, PTH secretion is reduced or shut down. This direct responsiveness highlights their critical endocrine role.
Makes sense. Does it work alone?
No, PTH works in conjunction with calcitonin, which comes from the thyroid C cells, as we mentioned.
Right, the calcium-lowering one.
And also vitamin D, to precisely regulate both calcium and phosphorus levels. It's a beautifully coordinated effort to keep these vital minerals right where they need to be.
Okay, so let's dive into that role in calcium and phosphate metabolism. How does PTH raise calcium when it's low?
When your serum calcium levels dip, elevated PTH steps in and does a few things. First, it triggers the release of calcium from your bones, a process called bone resorption.
Takes calcium from bone storage.
Yes. Second, it tells your kidneys to reabsorb more calcium ions from the urine that's being formed, reducing the amount you excrete.
Less calcium lost in urine.
Correct. And third, PTH helps activate vitamin D, which is absolutely necessary for your gastrointestinal tract to absorb calcium effectively from the food you eat.
Boosts absorption from food. Wow, a multi-pronged attack on low calcium.
It really is. And while PTH is busy raising calcium, it's simultaneously regulating phosphate. It actually decreases the reabsorption of phosphorus in the kidneys.
Gets rid of phosphate.
It leads to increased renal phosphate excretion. This creates a generally inverse relationship in the blood. When PTH raises calcium, it often lowers phosphate, helping maintain that crucial balance.
Interesting. So PTH, calcitonin from the thyroid, and vitamin D all work together for calcium homeostasis.
Exactly. Calcitonin acts antagonistically to PTH, helping to lower serum calcium levels when they get too high, completing the regulatory loop.
Okay. Now, what happens when there's an imbalance in PTH? Let's look at hyperparathyroidism first. Too much PTH.
Right. Increased PTH. This can be caused by things like a parathyroid adenoma, which is a benign tumor on one of the glands that's the most common cause.
The tumor making too much PTH?
Yes, or sometimes hyperplasia, where all the glands are enlarged. It can also be a compensatory response to chronically low calcium. We call that secondary hyperparathyroidism.
Secondary. Like the parathyroids are trying to fix low calcium.
Exactly. You often see this in conditions like chronic renal failure, where the kidneys aren't activating vitamin D properly or handling phosphate well, leading to low calcium, which then stimulates PTH, or severe vitamin D deficiency itself can do it.
Okay, what are the effects of too much PTH?
The main effects are hypercalcemia, elevated serum calcium, and often hypophosphatemia, decreased serum phosphorus. Symptoms can be vague, like fatigue or weakness, but can also include things like kidney stones, bone pain, or even hypertension due to the effects of high calcium.
How's it diagnosed?
Diagnosis typically involves finding elevated PTH levels alongside elevated serum calcium. That combination points strongly to primary hyperparathyroidism.
Okay, now the other side, hypoparathyroidism, too little PTH.
Correct. Decreased PTH. This can happen if the parathyroid glands are inadvertently damaged or removed during neck surgery, like a thyroidectomy.
Surgical complication.
That's a common cause. It can also be a compensatory response if calcium levels are already high due to other reasons, like certain cancers or vitamin D intoxication. Autoimmune diseases can also target the parathyroids, and even severely low magnesium levels can impair PTH secretion.
What happens with low PTH?
The effects are the opposite of hyperparathyroidism. You get hypocalcemia, low serum calcium, and often hyperphosphatemia, high serum phosphorus.
Low calcium, high phosphate.
Yes.
Yes.
And clinically, the low calcium can cause significant problems because calcium is critical for nerve and muscle function. You might see tetany, muscle cramps, spasms, tingling, especially around the mouth or in the hands and feet. In severe cases, it can lead to seizures or cardiac arrhythmias.
Wow, low calcium sounds dangerous.
It can be very dangerous. Diagnosis involves finding low PTH levels together with low serum calcium and usually elevated serum phosphorus.
All right, moving on down the endocrine chain. Let's talk about your adrenal glands. Those amazing little organs sitting right on top of your kidneys, often called your stress responders, right?
That's a big part of their job, absolutely. And adrenocorticotropic hormone, or ACTH, also known as corticotropin, is a key player in their function.
ACTH, where does that come from?
ACTH is secreted by your anterior pituitary gland, that master gland again, and its release is controlled by corticotropin-releasing hormone, or CRH, from the hypothalamus, another axis.
The HPA axis, hypothalamic pituitary adrenal.
You got it. ACTH primary job is to travel to your adrenal cortex, the outer part of the adrenal gland, and stimulate it to secrete cortisol, that main stress hormone, and also some androgens.
Stimulates cortisol. Is there feedback here too?
Absolutely. It's another classic negative feedback loop. Increased cortisol levels in the blood feed back to the pituitary and hypothalamus to suppress further ACTH and CRH release. Keeps things in check.
Makes sense. Does ACTH vary during the day?
It does. ACTH follows a distinct diurnal rhythm. Levels naturally peak in the early morning, usually between 6 and 8 a.m., and are lowest late in the afternoon or around bedtime.
High in the morning, low at night.
Typically, yes. However, this rhythm can be totally disrupted in disease states like Cushing's syndrome, where there's too much cortisol, Addison's disease, where there's too little, or even just chronic stress.
Okay. So how do we interpret ACTH levels in tests? What does high ACTH mean?
Increased ACTH levels can point to a few things. It might indicate Addison's disease, which is primary adrenal insufficiency. Here, the adrenal glands themselves are failing, so cortisol is low, and the pituitary ramps up ACTH, trying to stimulate them.
High ACTH, low cortisol adrenals failed.
Correct. Or you could have extremely high ACTH levels, often above 200 pgml. This is highly suggestive of ectopic ACTH syndrome.
Ectopic, meaning from somewhere else.
Exactly. A non-pituitary tumor, maybe in the lung or pancreas or thymus, is improperly producing ACTH.
Wow. Okay, what else causes high ACTH?
It can also point to a pituitary adenoma that's overproducing ACTH, leading to Cushing's disease, Cushing's caused by the pituitary, or just physiological stress, physical or emotional, can raise it.
Okay, what about low ACTH?
Decreased ACTH levels might suggest primary adrenocortical hyperfunction. This could be due to an autonomous adrenal tumor, an adenoma or carcinoma, that's churning out cortisol on its own, which then suppresses pituitary ACTH.
Low ACTH, high cortisol adrenal tumor is likely.
That's a key pattern. Or low ACTH could signal secondary hypoadrenalism. Here, the pituitary isn't producing enough ACTH, so the otherwise healthy adrenal glands aren't being stimulated, leading to low cortisol.
Low ACTH, low cortisol, pituitary problem.
Generally, yes. Also, taking steroid medications long-term will suppress natural ACTH production. So, interpreting ACTH always requires looking at the cortisol level and the clinical context.
Right, you need both pieces.
Oh.
Is there a test to directly check the adrenal response?
Yes, absolutely. To really pinpoint the problem, especially when suspecting adrenal insufficiency, we use the adrenal stimulation test, or ACTH stimulation test, sometimes called the Cosintropin test.
How does that work?
This test assesses whether the adrenal glands can respond properly. It involves measuring blood cortisol levels before and then after administering a synthetic ACTH-like drug called Cosintropin. This drug directly stimulates the adrenal glands.
Like sending a direct order to the adrenals, bypassing the pituitary.
Precisely. It asks the question, adrenals, are you capable of making cortisol if I tell you to?
Clever. How do you interpret the results?
The interpretation is quite telling, especially for adrenal insufficiency. In primary adrenal insufficiency, Addison's disease, if the adrenal glands are damaged, there will be little or no increase in cortisol after the Cosintropin stimulation. They simply can't respond.
No response. That Addison's confirmed.
Generally, yes.
Okay.
However, if it's secondary adrenal insufficiency, meaning the problem is with the pituitary not sending ACTH, the adrenal glands themselves are usually healthy. So when you give them the direct Cosintropin stimulus, you'll see a significant increase in plasma cortisol. They can respond.
Good response. Adrenals are okay. Problem is likely pituitary, secondary.
Exactly. A normal, robust response to this test effectively rules out primary adrenal insufficiency. It can also help in evaluating Cushing's syndrome. For example, if Cushing's is due to bilateral adrenal hyperplasia, overstimulated glands, you might see an exaggerated cortisol rise. But if it's due to a hyperfunctioning adrenal tumor that's already maxed out on cortisol production, you'll see little or no further increase after stimulation.
Very useful test for sorting out adrenal issues. Wow, okay, we've covered a ton about glucose, thyroid, parathyroid, and the adrenals. But the endocrine system truly is this vast, interconnected network, isn't it?
It really is a symphony of chemical messengers, just like you said earlier, and there are several other hormones that play equally critical roles, giving us insights into everything from growth and fertility to even specific tumor activities.